Anuradha Jain is a medical graduate and has advanced qualification in public health. She has 10 years experience in working in national health programs. At present, she is a consultant for public health planning at the NHSRC Delhi. Her areas of expertise include public health policy research, evaluation, impact assessment at the state and district levels of planning. And she has several publications to her credit. Anuradha?
Introduction. I'm presenting this particular presentation on behalf of my other two colleagues, Ms. Jimli Barua and Dr. Ritupriya. My story is going to be rather simple and would be spelled out in very simple words. Why we did this study, what forced us to look into the issues of planning process, and what is the way forward that we propose after doing this study. To begin with, we've been working as a planning team for the last 4 years at a national level in National Health System Resource Center. And the core activity of the planning team has always been the district plans and the state plans. When I say district plan, I also mean the block plans and the village plan. But to be very honest, in the last 4 years, the kind of activities that have gone in or the kind of plans that have been made, their use, their utility, their use in NRHM per se in the outcomes have not been seen. And we were also, during our common review missions or when the concurrent evaluation report came in, we were trying to find out the reasons why, despite so much of effort that is going into district planning from our side or from other organizations, there are many other organizations who are helping out in district planning and state planning, why aren't these plans getting used? Why aren't the implementation is being done on the plan? Why financing is not happening according to the plans? And that was the very basic reason we started looking into this whole study or the process. These are some of the quotations from NRHM Implementation Framework book, which we all call the Blue Book at the national level. And to begin with, what I understood about planning was from this book. And on page 23, it says that the decentralized planning, preparation of district plan, community ownership of the health delivery systems, and intersectoral convergence are the pillars of the superstructure of NRHM on which it would be built. The other quotation says, the intent of a newly launched NRHM, as mentioned in the core strategy, is that it will promote community ownership and decentralized planning from village to district level. So what it meant was a bottoms-up approach. This is supposed to be through a participatory process by strengthening evidence-based effective monitoring and evaluation. Now, all the components that we all have been talking since yesterday had been covered under this particular paragraph. And what I understood as a planner at that point of time was that if you have to make a district plan, the district plan should be a combination on where the community owns a plan and the facility is contributing to that plan to assess the health needs and then provide it. But fortunately or unfortunately, the way it's written must have happened, is happening, but probably the intention or the way it went was not very correct. And the reasons why it did not went very correct is what the study explores. I think I don't need to go through this slide because what is decentralization and all has been done. But what I would like to all of you to go through in this slide is why district plans. District plans were mandated to ensure equity in resource distribution, access to services, utilization of services, quality of care, community need perception, and socio-epidemiological situation. I have not written social determinants because when you say socio-epidemiological situation, I believe somewhere it has to be covered under this. Now, the NRHM gaps, there have been achievements. Please don't misinterpret me as quoting that NRHM has not made achievements or not, has not reached to a level from where people have started thinking about UHC or a concept like UHC. But to say that, there has still gaps. And we are just trying to analyze what those gaps are. The CRM for the last 4 years have been happening, and this CRM have been pointing out continuously on certain areas which have either been overlooked or has not been given amped attention by the policymakers or the implementers to look into these areas. The concurrent evaluation also, though it has not been very widely used by a lot of people, that's what I came to know during this study and during my interviews, that a lot of people have not been using concurrent evaluation, but it has a lot of good findings in terms of district planning or the village planning that we came across. The gaps that we found, and they were quite correlated with each other, which were leading, according to this study, to what we call reaching the unreached. Because as Professor Miller was yesterday showing that whatever in the low-income group countries, the policies that were being made or the programs that were being implemented were only benefiting the upper middle class and the upper class, and the unreached still remain unreached in most of the places. So similarly, why the unreached in India also remain unreached? These three reasons basically are somewhere responsible for it according to our study. One is the financial flow. The financial flow is not according to the district needs or the district plans. I'll elaborate on this point at a later stage. The fund is blocked in pipelines. When I say the fund is blocked in pipeline, it also means something which is like if the funding is norm-based and not need-based, certain facilities utilize it, certain facilities do not utilize it, and the ones that are providing services and utilizing it are the ones that are exhausting their funds, and the others are the ones who are keeping it, and why they are keeping it is what the study is pointing out at. Poor availability of HR for finance management. The whole management structure had been always a problem. Now, when I say finance management structure, program management structure is something that all of us or the policy makers have looked into. But finance management structures are something which always get, affected during this course of policy making. Poor flexibility options in flexible funding mechanisms. When I say this, what I mean is you have certain strategy plan or the line item plan under which the budgets go. And between these line items, the flexibility of moving the funds is not there. I think it will be difficult for people who have not seen the financial management group structure outlines, but those of you who have seen it would understand what I'm trying to say is that there are specific strategy heads that are given over there, even the sub-activity heads. And even when the money goes there, there's no flexibility for a person to move in between those activity heads. And so the flexibility, the so-called flexibility of NRHM becomes very, very non-flexible. The governance structures, poor institutional capacity, lack of dissemination of guidelines, unwillingness to delegate financial powers. Now, ma'am has already, my previous speaker has already talked about devolution and things like that. So when she was giving the example of Rajasthan, Rajasthan is a very typical example, madam, where the powers were transferred to the PRIs, and the process was like, first they have to look into just the administrative part of this story. The financial powers were not delegated to them. When the financial powers, they did not have the authority to either give somebody their payments. They were just authorities to sign on the papers. That kind of delegation did not help them. And in the course of 3 years, the government decided to give them the financial powers also. But now there is a whole lot of resistance coming up for that, because as per the senior staff in the districts, taking your salary from PRIs is something which is very, very non-acceptable to them. And, transferring your power to PRIs is something very, very, but the way it has been done, the transition could have been very, very smooth if there would have been proper guidelines, there would have been proper way of transferring this power. So all that matters when you start speaking of community owning a system, a community owning a program, and that is where this kind of governance and the transfer of powers in governance start affecting a program delivery. Planner, implementer, and monitoring, all different teams. What I mean to say here is, whoever is planning is not implementing, whoever is implementing is nowhere in the monitoring part of the story. So there are 3 different group of people who are monitoring, planning, and implementing. They have no interface with each other. Administrative delays in enabling orders. When an enabling order starts from the top, center to state, to district, to village, there is a mismatch over there. The planning process itself, the plan at district and below is gone into a disuse atrophy. This term I have picked up from my medical background, but it quite holds good here also. Plans are normative and template based. Innovations, social determinant, convergence remain the most affected due to lack of contextual evidence-based planning process. When I say this, I mean this because when you use data for planning, you'll use data from DLHS, NFHS. Nobody would use their own HMIS on the...
Sorry, this is a terrible bell, but you have to wind up.
Coming up on the research questions, the objective of this in planning process was so central to NRHM when why the DHAP is not being used for financing. The objective of this study was to document the processes of planning under the NRHM at state and district and village level and to analyze their outcomes. What are the probable reasons of failure of those plans? These were the 2 basic questions that we started. The methodology I've already described to you in detail. The only thing that was left out is that we analyzed around 29 program implementation plans. We analyzed 20 district and block plans, and 14 states village plans were analyzed before we went out into the field with the information that was left as a gap with a matrix to fill it up. These were the trends in planning process, the village, block, district, and the quality of the plans and their utilization. The trends clearly show that the quality of the plans were not so good, or they were not so effective that the planners or the implementer or the policy makers could use it or finance it based on these plans. The trends of the use have been that the village and the block plans have just been made for the sake of being making, and they were obsolete, never used even to be merged in the district plans. The state plan hardly used district plan for financing reasons. This is a list of the village plans and the block plans that were made, and most of them were template based. There were some that were descriptive with the social determinant and health needs. There were others where some sort of write-up was present, but very basic. This is a demonstration of how things went wrong for non-utilization of these district plan. They were bulky plans, there was poor ownership. The information in these plans were mostly non-contextual. The current, the framework in which these plans are made are that every year you start the planning cycle somewhere in September, the plans are made till March. The money goes to the states by the end of the July, and next September the planning process starts again. So the whole year one group of people keeps doing planning, and they are not the implementers, and those who are monitoring are not the implementers. So there are 3 different group of people who are doing this work, And there is non-concluding and non-contextual situation analysis that happen. The weak areas are never touched because they are so-called vertical area of planning and monitoring. And the norm-based funding is the other problem. And there is absolutely insufficient attention to the capacity building for planning process because of both willingness and non-availability of institutions. So what is the way forward that we propose? One is developing planning capacities. The other one is a time frame that has to be changed for planning. The 1-year cycle can be probably changed to a 5 years prospective plan. At the mid of 2.5 years, it can be reevaluated in terms of what is there. And the support to decentralized planning in terms of clear guidelines. And what a model district plan is what I leave you all with. The question that we all have to explore, because under UHC, again, we are rethinking of doing this district planning.